Assalamu alaikum everyone. I'm Reem, and today me and my friend Jenan are going to quickly go over the development of the cardiovascular system as well as mentioning the corresponding congenital heart disease. So first, we're going to quickly go over the development of the heart tube. As we all know, it's going to begin as two endothelial heart tubes. These two tubes are going to fuse with each other to give us one single heart tube, just like the one we can see on the right. This heart tube is going to have two ends, a top arterial end that is going to be called truncus arteriosus, and a lower venous end which is going to be called sinus venosus. Then several constrictions are going to appear within the tube, dividing it into the primitive atrium, primitive ventricle, and the bulbous cordus. Now moving to the development of the atrial septum. Before we quickly discuss the atrial septum, we need to understand how an important structure which is called the septum intermedium is going to form. So basically, as a quick orientation, this is going to be our primitive atrium and this is going to be our primitive ventricle. Between the primitive atrium and the primitive ventricle, a small canal is going to be present which is going to connect both areas together. This canal is going to be called the atrioventricular canal. Within the atrioventricular canal, an anterior and a posterior endocardial cushion is going to appear, or you can call them dorsal and ventral cushion. These two cushions are going to appear at opposite ends and they're going to keep on growing towards each other until they fuse and form a single structure called the septum intermedium. As you can see, the septum intermedium right here is going to divide the atrioventricular canal into right and left. These two sides are going to be the future side of the right atrioventricular orifice, which is the tricuspid orifice, and on the left side it's going to be the left atrioventricular orifice or the mitral orifice. Alright, now proceeding with the formation of the atrial septum. Again, this is going to be our primitive atrium and this is going to be our primitive ventricle. The primitive atrium is going to receive the blood that is going to flow through the inferior vena cava, which is originally coming from the umbilical vein that is coming from the maternal circulation carrying oxygenated blood. Blood is going to flow from the primitive atrium to the primitive ventricle. This part of the fetal circulation is going to be further discussed later on in the video in details. Now, starting again, this is going to be our primitive atrium and this is going to be our primitive ventricle. I'll zoom in so it can be clear. This structure right here is going to be the septum intermedium, which we just saw how it developed, and then from the cranial part of the primitive atrium, a structure that is going to descend downward is going to form. This structure is going to be called the septum perineum. However, at the beginning, the septum perineum is not going to completely fuse with the septum intermedium, and there is going to be a small pathway or passageway that in which blood can flow from the right atrium into the left atrium, and this space right here is going to be called the foramen perineum. As the septum perineum is going to move towards the septum intermedium and fuse with it, the cranial part is going to undergo apoptosis and the foramen perineum is now closed because the septum perineum has completely fused with the septum intermedium, while the cranial part is going to open, forming the second foramen, which is the foramen secundum, by which now instead of the blood flowing this way, the blood is going to go from the right atrium to the left atrium along the cranial side. Then to the right of the septum perineum, another septum is going to descend downwards, also moving towards the septum intermedium. However, it's not going to completely fuse, and this is going to be called the septum secundum, and a small here pathway is going to be open. So blood is going to come from the inferior vena cava, enter the right atrium. From the right atrium, it's going to go through this oblique pathway, which is going to be called the foramen ovale, by which the blood is going to move from the right atrium into the left atrium. This part is going to be very important during the fetal circulation, because the pressure within the right atrium during the fetal life is going to be higher than the pressure within the left atrium, which is primarily due to the fact that the lungs are not they're not functioning at all, because the majority of the oxygenated blood is coming from the maternal side. However, at birth, when the placental circulation and the umbilical cords are cut and the baby is delivered, the cold temperature, along with the fact that the placenta has been completely removed, is going to stimulate the first respiration, and the lung is now going to be completely functioning, which is going to increase the pressure of the left atrium, forcing these two structures to stick to each other. And it's going there, so they're like the septum perineum and the septum secundum, they're going to fuse with each other, and they're going to form, this is going to be the view that you guys can see if we look at the left atrial side. So this navy structure right here is going to be the septum perineum. Due to the increase of the pressure of the left atrium, is going to completely fuse with the pink structure, which is going to be the septum secundum, and a small depression is going to be formed, which is going to be the fossa ovalis. And this the limb of the fossa ovalis is going to be formed, or it's going to be originally formed by the septum secundum, but after birth it's going to be called annulus ovalis and the fossa ovalis. If this structure, or upon birth, this foramen ovale did not close by the fusion of the septum perineum and the septum secundum, we're going to have a pathology that is going to be called persistent foramen ovale, which is going to create an abnormal right to left shunt that is not going to be necessarily needed. And this is going to be further explained by later on in the slides by Jenan.
The first congenital heart disease that we're going to talk about is atrial septal defect, which is an acyanotic problem. Now, usually when we're looking at congenital heart diseases, some of them are shunts, or their problem is due to a shunt, and others are due to obstructions and constrictions. Most of the ones that we'll cover today are basically shunt related. There is an abnormal opening in the heart that causes blood to go in either directions, either left to right or right to left. Acyanotic problems are the ones that will have the blood moving from left, which is the side carrying your oxygenated blood, into the right, the deoxygenated blood. So for the most part, we will not see cyanosis, specifically in the early stages. So the first pathology that we'll talk about is atrial septal defect. So usually in fetal life, there is an opening between the two atria. This foramen ovale, initially it's called foramen primum, then secundum, and then ovale. This opening is important because the lungs in fetal life aren't working properly. So we need when the blood is entering, the blood is going to enter into the right atrium from your superior and from the inferior vena cava. And then when the blood is entering into the right atrium, it's not going to go into the lungs because there is no oxygenating coming from the lungs. So the oxygenated blood, because the fetal circulation is technically the opposite. So when the blood is coming into the right atrium, it's supposed to go directly into the left atrium in fetal life. So what happens is the movement of blood will allow the blood to go from the right side to the left side to then go into the aorta and then be pumped into the circulation. Now, when a child is born and the umbilical cord is cut, the lungs start to work normally. And when the lungs start to work normally, the pressure in the left atrium exceeds that of the right atrium. So the opening closes and it becomes a fossa, also known as fossa ovale, and then the limbus of fossa ovale or annulus ovale. Now, if this doesn't close due to whatever reason, the opening that remains is what causes ASD. So usually this opening, now in fetal life, again, the movement of blood would be from the right to the left side. But in a normal individual, in an adult, the pressure in the left side is higher than that of the right side. So the movement of blood will be from left to right. So again, it's just the idea that the opening between the atria remains patent and remains present. And what happens is the blood movement, like the gas movement, like any movement of any particle and fluid, moves from high pressure to low pressure. And in a normal, healthy adult heart, the pressure in the left side is greater than that of the right side. So the blood will move from the left to the right side. So it is an acyanotic heart disease or heart defect, with the blood moving from the left side into the right side. Now, initially, this pathology or this congenital heart defect is asymptomatic. The person will not present with any symptoms, especially if the pathology is minimal. Now, when we're looking at the opening, the placement of the opening does differ. Usually, almost always, or most commonly, the opening is in the middle of the interatrial wall, and it is what we call a secundum. Sometimes it could be in the lower aspect, and it's known as premium. Sometimes it could be higher up top, but most of the time it is in the middle wall or in the middle aspect. Now, the symptoms later on, they happen at 30 or 40 years. This is because the blood reaching the right side is becoming excessive. So we're starting to see volume overload. So with time, the right ventricle and the right atrium start to hypertrophy. And this hypertrophy will cause a lot of problems and ultimately reaching to pulmonary hypertension. And in pulmonary hypertension, in very severe cases, it becomes irreversible. Now, before talking about the severe complications, let's look at the findings that might result from the hypertrophy in the right side. First of all, one of the main findings that you will see upon examination is a parasternal heave, usually because of the hypertrophy of the right ventricle. Then we can see upon auscultations, we hear different murmurs, like an ejection systolic murmur and a wide but fixed S2 sound. Now, the reason behind this is because of the pulmonary valve. What happens normally, the aortic valve will close and the pulmonary valves, they don't close at the same time. So there is a slight split. But in the case of ASD, it is a bit more exaggerated and you hear it a bit more clearly, and it is fixed, meaning it is not affected by breathing. It is always present. This is because there is a lot of blood coming into the right side. So the pulmonary valve is taking a lot more time to close compared to the aorta. So the aorta is closing, or the aortic valve, is closing before the pulmonary valve. And so there is a wide but fixed splitting because, again, it's not affected by breathing. Now, the most important thing about this condition, if left untreated for a really long time, is the reversal that might happen in the shunt. This is called as Eisenmenger syndrome. Basically, what happens is, as mentioned, there's excessive blood moving into the right side. So there's hypertrophy. And this hypertrophy with time will cause the pressure in the right side to exceed that of the left side. And so the shunt will switch. Instead of being left to right, making it acyanotic, when the pressure becomes higher in the right side, it will switch. And this will cause it to become a cyanotic problem. And it will cause cyanosis, clubbing, and might also cause early mortality. Now, how can you diagnose someone with ASD? Usually there's multiple things that you can look at, like you can look at an ECG, an X-ray, and an echo. Usually echo is the most diagnostical one because you can clearly see the opening between the right atrium and the left atrium. But X-ray can also show you things relating to the ventricular hypertrophy. Usually when the right side hypertrophies, we see that the heart moves a bit upwards and to the left side. So usually that's what we see in a right ventricular hypertrophy, and if it was left, it would be the opposite. And also you can see the pulmonary vessels are a lot more filled with blood, again because of the pulmonary hypertension and because of the excessive blood going into the right side. Treatment is surgical. Usually open heart surgery is what is done to fix the opening, but there is a percutaneous closure, which is a simple procedure, minimally invasive, where a catheter is inserted to reach the opening, so it reaches the right atrium by the superior vena cava or through the femoral vein, and this inserts an umbrella-like kind of end of the catheter and closes the opening. Finally, a catheter-based patch can be done, which is essentially like a suture to close the opening, but this is very rarely done.
The development of the interventricular septum. I'm just going to quickly mention the sequence of the structure in which events were going to happen or structures are going to form. First, we had the formation of the septum intermedium. Later on, we discussed the formation of the interatrial septum. And now we're going to be discussing the formation of the interventricular septum. Just keep in mind that this view right here is the coronal section of the primitive atrium and the primitive ventricle. And this upper part right here is going to be the smooth outflowing part of the ventricle, which is formed by, which embryologically originate from the bulbous cordus. This is, for the sake of the explanation, since we're going to be only seeing one part of the heart, this is going to be our left atrium, and this is going to be our left ventricle. As blood is flowing from the primitive left atrium into the primitive left ventricle, the blood is going to cause, or the force of blood is going to induce the endocardial lining, which is the most innermost structure right here, or the innermost layer, to form a upward protrusion. this upward protrusion is going to form the muscular part of the interventricular septum. As blood is continuing to flow within the muscular part, small cavities are going to form. And these cavities are going to give rise to the rough inflowing part, which is going to be the trabeculate muscle and the papillary muscles as well. Then the two bulbar ridges are going to form within the walls of the bulbous cordus, which are going to be the two green structures right here. So up till now we had the upward projection of the muscular part from the primitive ventricle. Two bulbar bridges are going to form. They're going to finally fuse together and form the bulbar part of the interventricular septum. The purple structure right here is going to be the septum intermedium. At the end, the septum intermedium is going to shrink and form the rest of, or the membranous part of the interventricular septum. I know it might be a bit confusing of how this entire thing is going to separate the two ventricles, but if we look at it from this side, we can say that this is the left ventricle and this is the right ventricle. The orange structure right here, which is the same thing if you look at it from the coronal view, is going to be the muscular part that projected from the endocardial lining of the primitive ventricle. The purple part is the membranous part that formed from the septum intermedium, and the green part, which is the closest part to the bulbous cordus, is going to be the bulbar part of the septum, the interventricular septum. Then the interventricular septum is going to open to the two partitions of the bulbous cordus, which is going to be the smooth outflowing part into the aorta on the left and the pulmonary trunk on the right. If there was any abnormality during the development of this interventricular septum, whether it was from the muscular part, the membranous part, or the bulbular part, it is going to result in something called ventricular septal defect, in which a shunt or like an opening between the two ventricles, so like an opening could be right here, the bulbular part, resulting in an abnormal pathway in which blood can flow. And this is going to be, again, further discussed by Jenan.
The second congenital heart disease that we're going to be talking about is also an acyanotic problem, since the shunt will also be left to right, but this is a ventricular septal defect, so it's going to be happening in the ventricle. So the opening, or technically in fetal life, the interventricular septum has a membranous and a muscular part. The membranous part is the part up top, and then the muscular is the part down below. So usually due to whatever cause, it could be a congenital problem, and sometimes VSD is due to an MI. So as a complication of an acute myocardial infarction, VSD might develop, and it usually differs in the placement of the opening. Sometimes the placement could be in the membranous part, and usually that's more severe and needs more surgical intervention. And sometimes it could be muscular, and if it is muscular, usually it's very small ridges and very small openings and might not even need treatment. Usually the findings and the pathogenesis of it are very similar to ASD. It's just VSD progresses to a reversal shunt, so the shunt becomes right to left a lot quicker than ASD. What happens is, again, the pressure in the left ventricle, or the pressure in the left side of your heart, is a lot higher than that on the right side of the heart. So the blood will start to move from left to right and ultimately cause the shunt, which will cause more blood to reach the right side, causing overload into the right side of the heart, which will ultimately lead to hypertrophy and then pulmonary hypertension. And because the blood is continually going into the right side, not enough blood is going out into the aorta and reaching the body, so low cardiac output is happening. And usually low cardiac output can be manifested by certain symptoms like exercise intolerance, fatigue, and even syncope. Upon physical examinations, a murmur can be heard on auscultation. Usually a pansystolic murmur is heard throughout the whole time your ventricles are contracting. There is a murmur heard, and usually also a harsh murmur because of the very severe gradient in pressure. The pressure in the left ventricle is 120 millimeter mercury, and in the right side it's 30, whereas in the atria the difference between them is very minimal. So in ASD you don't hear a harsh murmur. That's mainly heard in the VSD. Again, Eisenmenger syndrome is also present in VSD, but usually develops a lot quicker, so the shunt can shift or reverse very quickly compared to ASD. For investigations or for diagnosis, very similar An ECG can be done to see the right ventricular hypertrophy. X-ray can also be done. You can see the lung congestion because of the blood going into your lungs. Or an echo can also be done, and you can clearly see the opening or the septum between the left ventricle and the right ventricle. For treatment, if it's mild or if it's just simple muscular openings, sometimes we don't do any repair, but usually a prophylaxis is given before a dental procedure to prevent infective endocarditis. Sometimes catheter-based repair is done, but usually if it's a very severe case, surgical repair is the most efficient way to manage it, and usually it's done before it develops into pulmonary hypertension. Usually it's done very early on because it progresses quite quickly, so surgical repair is done early on compared to what we saw in ASD.
Alright, continuing with the fetal circulation. The fetal circulation refers to a specialized system of blood flow that is going to exist in the developing fetus before birth, that is very essential to supply the fetus with the oxygenated blood. Now, the fetal circulation is opposite to the adult circulation, by which oxygenated blood are going to flow through the veins and deoxygenated blood are going to be drained into the arteries. It's more kind of similar to the pulmonary circulation in the adulthood. We're gonna start with the placenta, and at the beginning of the fetal life, we're gonna start with 4 blood vessels. 2 of them are going to be veins, and 2 of them are going to be the umbilical arteries. However, at the early beginning of the fetal life, the right umbilical vein is going to disappear, while the left umbilical vein is going to persist. So, oxygenated blood carried from the maternal side through the placenta is going to flow through the umbilical vein, this red structure right here, and then from the umbilical vein it's going to go through the liver, it's going to drain into the sinusoid of the liver, and then from there it's going to enter into the inferior vena cava. And in addition to the special circulation, the fetal circulation has around 3 bypass shunts that are going to be like some sort of a shortcut for the blood to flow through. These shunts are going to be very essential throughout the fetal life. However, after the baby is born, they're going to either disappear or they're going to be converted into other structures such as ligaments. As I was saying, so usually the blood would have to pass through the liver, from the liver sinusoids into the inferior vena cava. However, this entire structure right here, which is called the ductus venosus, is going to be a vein that is going to connect the umbilical vein directly into the inferior vena cava. So the oxygenated blood would sometimes pass the liver and empty directly into the right atrium. Now, during the fetal life, it's going to be called ductus venosus and acts like a vein. However, after delivery, it's going to persist as the ligamentum venosum of the liver. Then from the right atrium, blood is going to flow through to the left atrium through the foramen ovale, which we have just discussed earlier throughout the development of the intra-atrial septa, which is basically the small opening by which it's going to act like a shunt, by which oxygenated blood is going to flow from the right atrium into the left atrium, and then blood is going to flow from the left atrium into the left ventricle, from the left ventricle into the ascending aorta, into the aortic arch, which is going to distribute the blood into the neck and the upper extremities, and then it's gonna go downwards, or the deoxygenated blood is going to go through the descending aorta back into it. So we started with the first shunt, which was ductus venosus, bypassing the liver. Then we have the foramen ovale, which is going to bypass the right ventricle because of the lungs are not actually functioning, so they don't need they don't need to take up the blood supply. We're gonna drain it, we're gonna move the blood from the right atrium into the left atrium, from the left atrium into the ventricle, to the rest of the body. The deoxygenated blood is going to flow from the head, neck, and the arm into the superior vena cava, from the superior vena cava into the right atrium. From the right atrium, it's going to enter the right ventricle, and then from the right ventricle, it's going to flow into the pulmonary trunk, and then there's going to be a special connection with the pulmonary trunk and the descending aorta called the ductus arteriosus. The ductus arteriosus is going to bypass the lungs because of their high resistance, and this is going to be our third bypass shunt, in in which deoxygenated blood is going to flow from the right ventricle through the pulmonary trunk into the ductus arteriosus, then connecting it to the descending thoracic aorta, and then in which it's going to keep on draining the rest of the deoxygenated blood from the body, while it's going to reach finally in the common iliac artery, through which the right and left umbilical arteries are going to drain the deoxygenated blood, returning them back into the placenta. Throughout the fetal life, this artery is going to act like a shunt, bypassing the lung. However, after the baby is born, it's going to be converted into ligamentum arteriosum, as well as the two umbilical arteries. They are going to become obliterated, forming the medial umbilical ligament.
Last, acyanotic congenital heart disease is patent ductus arteriosus. So before understanding the pathology, just a quick overview of what happens in embryological life. When the blood is coming, oxygenated blood is coming via the umbilical vein into the right atrium. The blood is either going to go into the left atrium via the foramen, or it's going to go down into the right ventricle, up into your pulmonary trunk. And then what happens is there's an opening between the aorta and the pulmonary trunk, because there is no reason for the blood to go into the lungs, since the lungs are not working. So usually what happens is the blood is supposed to go down into the aorta, specifically to the descending part of the aorta, because the ductus arteriosus, this opening connecting the great vessels or the great arteries, happens after the brachiocephalic artery, left common carotid, and left subclavian. So usually the blood that is going to come from the right ventricle is going to go and supply the lower half of your body. Now in certain individuals, what happens is this opening, the ductus arteriosus, remains patent. It stays open. And so it presents with pathologies and abnormalities. So what happens in fetal life, the blood goes from the right side to the left side. But when the baby is born and we have differences in pressure, the aorta will start to have more pressure than the pulmonary trunk. So the blood will start to go from the aorta to the pulmonary side, to the pulmonary artery, and to the pulmonary trunk. So what happens in turn is that the right ventricle is starting to push against a higher pressure. So with time, the right ventricle will hypertrophy and might even reach to a point of right ventricular failure. And since it's all in the right side, this might lead to pulmonary hypertension. Excessive pressure and excessive buildup of pressure in the right side will then lead the pressure in the right side to exceed that of the left side, and so the shunt will reverse. So instead of the shunt being left to right, it becomes right to left, and this is again what's called Eisenmenger syndrome. So the blood will start to go from the pulmonary trunk into the aorta because the pressure switched. The pressure is higher in the right side. So usually what happens is very similar, but we see it in the left side. So now there's more blood coming and pooling into the aorta, so the left ventricle is pushing against the higher afterload. So with time, the left ventricle will hypertrophy and ultimately result in failure. Now, an interesting thing about the presentation of cyanosis when it becomes a cyanotic problem, or when the shunt reverses, it basically is, it just has to do with the idea of the placement of the ductus arteriosus. So as I just mentioned, the opening is happening after the vessels up top. So it's after the brachiocephalic, left common carotid, and left subclavian, which go and supply the upper half of our body, the head, the neck, and the upper limbs. So usually this duct is present, or this opening is present after these arteries. So the deoxygenated blood is going to go into the descending aorta, thoracic aorta, and abdominal aorta. And so the cyanosis is usually a lower limb cyanosis. This is what we call differential cyanosis. So usually lower limb cyanosis presents in patent ductus arteriosus, unlike VSD and ASD, where it's just a generalized cyanosis happening because of the reversal of the shunt. Also, a machinery murmur is present because of the mixture of blood and the change in blood that we see. Investigations and diagnosis wise, usually an echo is seen. You can do an echo and a Doppler and you can see the opening in the patent ductus arteriosus. Now, in certain cases, if patent ductus arteriosus was to be present with another congenital heart defect, like transposition of the great arteries, usually keeping it open is very important for survival. But if it presents alone, or if it presents in a certain pathology where I don't need it to be open, treatment is very crucial and very important. Surgical ligation is an option, and it's usually done as a thoracoscopic surgery. And then we also have the administration of any antiprostaglandin medication. This is usually done in preterm babies because basically you want to inhibit the production of prostaglandin, specifically prostaglandin E2, which will essentially help close the opening in the ductus arteriosus. And in adults, most of the time, the kind of intervention of choice or the treatment of choice is to do a transcatheter occlusion to just kind of shut down or close the opening so that I don't have any mixture of blood or reversal of shunt.